So I'm Dr. Patrick Jones with Southeast Orthopedics. I'm one of the sports medicine specialists, and today I'm going to talk a little bit about one of the most common knee injuries we see in sports medicine, which is a tear to the anterior cruciate ligament, or ACL. So what is the ACL and how common is this injury? Well, about 200,000 ACL injuries occur every year in the United States. Typically, these are athletic-related injuries. We've all seen NFL tape where a patient pulls up with their knee extended and has an ACL tear. Well, what is the ACL? So when we look at the knee model here, this is the anterior cruciate ligament right here, this ligament right here. And what this ligament does is it prevents rotational instability of the knee, such that when it's torn, the lateral femoral condyle will externally rotate off of the back of the tibial plateau. And this can lead to tearing of the meniscus and damage of the cartilage. When patients typically injure this ligament, the knee is typically in a straight position and they have a non-contact twisting injury. This results in pain, swelling in the knee, sometimes difficulty walking, and can also lead to other injuries in the knee. Patients will typically come to me after this has happened, and we will obtain an MRI of their knee, and this will confirm tearing of the ACL and other damage to the knee as well. When we talk about how to treat this injury, very few patients can have this treated without surgery, bracing, depending on their lifestyle and what they want to get back to. But for most patients who are young and want to get back to activities such as playing pickleball, tennis, or other athletic pursuits, an ACL is typically important so they can get back to changing directions quickly, jumping, and activities such as that. So when we talk about how to rebuild or reconstruct the ACL, there are several options available to us to take a piece of tendon and use that from the patient to rebuild the ACL. We call that an autograft ACL reconstruction. There are essentially three options available to us. One is to take a strip of the patellar tendon with a little piece of bone from the tibial tubercle and a little piece of bone from the patella. We can take the hamstring tendons, which run behind the knee, or we can take a little strip of the quadriceps tendon. The quad tendon is probably the newest graft that's been used and becoming one of the more popular grafts to be used. All of these autograft options have pros and cons associated with it, and it's certainly worth a discussion with every patient about what their goals are to get back to and what graft makes the most sense for them. For some patients that are a little bit older, an allograft, or a tendon that comes from a cadaver, is a very acceptable option, which does not lead to any what we call donor site morbidity, which is pain at the site of the harvest. But that's typically reserved for patients that are a little bit older and would not be appropriate for a young athletic patient. What is involved in ACL reconstruction? Well, after we either take that graft from a donor or we take that graft from the patient, we will then use an arthroscope through poke holes in the front of the knee to visualize the knee, remove the old ACL. We'll drill a socket or tunnel through the femoral condyle and a socket through the tibia, and we will put the new graft or new ACL in that position and then secure it in place. Surgery is outpatient, takes probably an hour to an hour and a half to do. At the same time, we'll address additional pathology, whether that's cartilage damage or meniscal tearing. And then afterwards, the patient will be discharged home later that day. Depending on the damage that's done to the meniscus, the patient will either be on crutches for a period of 2 weeks to 4 weeks, or they'll be weight bearing as tolerated in the brace. They'll usually start in physical therapy 4 to 5 days after surgery, working on range of motion, and then proceed through physical therapy, working on range of motion till about 3 months. At 3 months, I'll typically allow patients to start doing some high impact activities such as jogging. And then probably around 6 months, we let patients start getting into what we call sport-specific kind of training. So that's side-to-side motion, jumping, things that would replicate what you would do on an athletic field, with the anticipated return to competition about 9 months from injury. The outcomes from ACL reconstruction are extremely good, with 80% of patients returning to the sport that they previously played before the injury. There are some considerations with that going forward, including bracing and the level of activity they want to get to, and patient regaining confidence in their knee. But very common injury with a very good treatment pathway for it. It's one of the most heavily researched topics within sports medicine, and the technology is always improving to allow options for our patients.